This is a discussion about the pros and cons of using medication-assisted treatment versus conventional treatment for those addicted to opioids by Lisa Campbell and myself, Christine Bowen. Throughout the world, the misuse of opioids is the main reason for treatment services and the fastest growing problem with substance use in the United States. The three medications approved by the FDA for opioid addiction are methadone, buprenorphine, and naltrexone. Due to alterations in stress-responsive, opioidergic, and dopaminergic pathways, long-term treatment is required. Detoxification, intensive inpatient treatment, and psychosocial therapy have been attempted but not proven to be as effective in treating opioid addiction as medication-assisted treatment. Extensive research shows that each of the three available medications used to treat opioid addiction have superior treatment outcomes to non-medication-based therapies. Methadone is an opioid agonist, buprenorphine is a partial opioid agonist, and naltrexone is an opioid antagonist. The injectable form of naltrexone is effective more than the oral form. The stress-responsive alterations due to opioid addiction can be corrected with the use of medication-assisted treatments, or known as MAT. The withdrawal symptoms of opioid addiction can drive someone to want to continue using. With methadone, major components of both the positive and negative reinforcing effects of short-acting opiates were reduced and craving subsided, thus allowing the addict to concentrate on non-drug-related activities. Studies of methadone and Suboxone prove high efficacy rates. There are little to no effects on the body, and usually there is a weaning system to stop the drug abuse. If someone stops using heroin, then there is less risk of diseases like HIV and hepatitis, which are contracted from using dirty needles. Using an approach like this aims to give respite from drug craving and withdrawal symptoms without giving patients an intense high like with heroin. Looking at the neurobiological aspects to this treatment, Suboxone is an alternative method to abusing opioids. This medication blocks the effects of opioids, the cravings, and the withdrawal symptoms. And buprenorphine is not as widely studied as methadone, but the safety of using it has shown it to be just as safe as a placebo. Before 2012, the Hazelden Bedford Clinic was against MAT, but now utilizes it in their recovery program. The biggest public health organizations, including the Center for Disease Control and Prevention, the National Institute on Drug Abuse, and the World Health Organization, all acknowledge medication-assisted treatment's medical value, and experts often describe it as the gold standard for opioid addiction care. Methadone has been proven to be effective in reducing the use of heroin, sustaining long periods of self-restraint, increase in drug treatment, and reducing the risk of deaths caused by overdose. It consists in the replacement of the illegal drug, which has a 2 to 3 hour half-life, with a prescribed opioid, which has a longer half-life and a good U receptor activity. The role of buprenorphine in the treatment of opioid addiction is not simply replacement of an illicitly used opioid for a medically supervised opiate, but rather as a medication that corrects many of the neurobiological processes contributing to relapse. There are always risks with medications, but this controlled substance is heavily monitored. The effectiveness and benefits the medication gives patients supersedes risks, and many studies have been done to prove this. One study's sole purpose was to provide a preliminary assessment of the safety, tolerability, symptom control, and acceptability of buprenorphine naloxone buccal films for the maintenance treatment of opioid dependence in patients converted from buprenorphine naloxone sublingual tablets or film, as well as determine the conversion ratio for switching patients from the SLBN to the BBN. The oral form of buprenorphine is not as effective as the sublingual form. There are developments being made in a subdermal implant that would last for 6 months. One example of maintenance therapy is the methadone for opioid addiction. With methadone, there is a potential for abuse, and a person can become addicted to it. Some people may not be able to keep up with the program because they have to go to a clinic every day if they are outpatient and receive drug testing. The risk for relapse is high with opioids, and the methadone maintenance program can last longer than a year. There are also some side effects that go along with taking methadone, which include constipation, sexual dysfunction, nausea, frequent urination, and, as mentioned above, addiction. People continue to use the opioids due to the negative reinforcement of withdrawal symptoms. To prevent the chance of death with the injectable form of buprenorphine, naloxone can be added at a 4-to-1 ratio. The naloxone helps by reducing deadly respiratory depression. The medication should be started under supervision and not stopped abruptly. If the effectiveness ceiling of buprenorphine is reached, the person may need to switch to methadone. Some critics state it is substituting one addictive drug for another. 12-step programs are standard for addiction. Some positive aspects of 12-step groups are to maintain abstinence, have support, and enhance spiritual and moral values. Cognitive behavioral therapy and contingency management have been effective forms of therapy as well. Those who have used psychosocial treatment only have had poor outcomes in recovery. In follow-up studies, it was found that 80% of those who received intense residential treatment went back to using the opioids within 2 years. There was also found to be greater mortality in psychosocial therapy versus methadone maintenance. Inpatient treatment can be expensive, and unless the person is highly motivated or is financially stable, they will not go. According to Solovitz, 2016, there are more deaths related to abstinence-only programs, and maintenance medication programs cuts death rates by 70%. In the 1960s, the United States methadone maintenance was implemented and was helpful in restoring people who were addicted to opioids to be more self-supporting and better functioning. The maintenance therapy was successful due to additions of comprehensive treatments like psychiatric evaluations and support like help with job placement, housing, and education. When the methadone programs were expanded, the comprehensive programs dwindled and the success in the program was diminished. There is an increasing need for effective treatments due to the concerning trends in North America of overdose deaths and non-medical use of prescription opioids. In 2014, 17 million users of opioids were estimated globally. The same year, prescription pain relief abusers were estimated at 1.7 million compared to 586,000 users of heroin in the United States alone. Not only does the treatment need to be more effective, but the front end of prescribing and regulation of the medication should also be improved. There are pros and cons to both medication-assisted therapy and psychosocial therapy for opioid addiction, but if used together, one would have the best outcomes. Heavy monitoring and alternative pain relief, along with regular therapy visits, would be the most effective in reducing the opioid epidemic. Educating communities and having better access to care would be beneficial. The aims of treatment are to reduce opioid-related deaths, reduce crimes in society, break the cycle of addiction, and prevent relapse, and integrate the person back into society. Individualized treatment that determines what is best suited for a person's recovery is the best route to improving their life. The dangerousness of medication maintenance therapy is concerning. Some of the ways this form of treatment can be dangerous is poor compliance, such as treatment may not be collected from the pharmacy or treatment center, or it may not be taken as directed. The distance needed to travel to the pharmacy and opening hours can influence the former, but supervised dispensing can overcome the latter. If the maintenance medication is dispensed more than once a day, or if the person experiences adverse effects, they may not want to comply with the program. The program should follow the guidelines and have psychological support and flexible dosing schedules. A positive therapeutic alliance is needed to promote compliance. Most people who detox or enter an MAT program relapse and cycle in and out of the program. Poor access hinders MATs, such as a limited supply of treatment facilities, creating long waiting lists, high thresholds for starting treatment, such as length of heroin abuse, intolerance of any other drug abuse, required attempts at detoxification, inability to pay for treatment, and complex insurance schemes. Free treatment and more harm reduction strategies should be employed. Prevention by reducing access to opioid prescriptions would be a key factor as well. Solovitz, 2016, reports that although pain relief prescriptions play a large role in people becoming dependent on opioids, that most people who abuse them get them from people they know and not as a prescription. There is overwhelming evidence that MAT is proven more effective in treatment for opioid dependence. If monitored and adhered to correctly with support and a therapeutic alliance with treatment staff, the person in recovery should succeed.